Next Chapter Podcasts.
When it's time to scale your business, it's time for Shopify. Get everything you need to grow the way you want. Like, all the way. Stack more sales with the best converting checkout on the planet. Track your cha-chings from every channel, right in one spot. And turn real-time reporting into big-time opportunities. Take your business to a whole new level. Switch to Shopify. Start your free trial today.
From the history of radioactive makeup to all the loony things Henry VIII did to ensure we never stop making movies about him, Weird History is a podcast that answers all the questions you didn't even know you had about the most unbelievable people, places, and events of the past. Based on the hugely successful YouTube channel, Weird History invites you to bone up on what it was like to use a public bathroom in ancient Rome while learning about the single worst year of all time. Don't worry, we missed it by a millennium or so. Then get the skinny on modern history, like the true story behind The Conjuring, and just what the hell Steven Seagal did to get banned from SNL. Let Weird History be your guide to the stranger side of history they don't teach you in school. Because the past is weird, a lot weirder than you think. Subscribe now, wherever you get your podcasts.
Our director of the state health department, Dr. Daniel Edney, I think said it best when he just said it to the Mississippi legislature, I believe. He said, Mississippi is not just 50th. We're 50th by a mile. He said if there were 60 states, we would be 60th.
Virginia, as you may or may not know, is the last state in the South without an abortion ban. And so what that means is that we have become a critical access point in the South, or a safe haven for many people traveling in across the entire southeastern region, but really the whole of the South.
You know what I'm saying? It's like we got a demo tape and nobody want to hear it, but it's like this, the South got something to say.
Hello, and welcome to Our New South, a podcast series presented by Levine Museum of the New South in Charlotte, North Carolina. Levine Museum connects the past to the future to realize the promises of a New South. To learn more and donate to projects like this, visit museumoftheNewSouth.org. Hi, my name is Kevin Blackistone of the Washington Post, coming to you from the University of Maryland, where I teach, and I'm joined by my co-host, Dr. Robert Greene II, a professor of history at Claflin University. Our New South Season 2 explores the complexities of the many New Souths that make up today's New South. The series highlights opportunities and challenges that different communities face, diving into censorship and healthcare, tourism and religion, struggles for rights and resources, and the global reverberations of New South culture.
We thank you for joining us on this journey and for making the show a Signal Award and Anthem Award winner. Follow the show, rate and review on Apple Podcasts, Spotify, or wherever you get your podcasts.
The South got something to say.
Today's episode of Our New South focuses on women's health care in the South, a topic that intersects with history, policy, and access to care.
We're eager to share these powerful conversations about the realities women face when seeking health care, from maternal health disparities to the impact of recent policy changes.
Yes, women's health in the South has long been shaped by systemic inequalities, from historical practices like forced sterilization to modern restrictions on reproductive rights. Rural communities in particular face a growing crisis of access to care.
But before we get to our guests, I would like to ask Dr. Robert Greene to reflect on the history of women's health in the South and how it continues to shape the present and what it means for the future of healthcare in the region.
The U.S. South's role in women's health care, both in the past and the present, cannot be denied. The 19th century physician J. Marion Sims, based in South Carolina, conducted numerous experiments to advance the broad field of women's health care. However, in order to do this, Sims experimented on enslaved Africans who had no way to deny consent for his work. Like so much else in American history, the South's relationship to women's health care, both historically speaking and today, is ultimately tied to its history of racism, white supremacy, and patriarchy. For Southerners in general, healthcare has always been a controversial and vexing problem. The climate and diseases native to the South have long plagued people living here. The already mentioned histories of white supremacy, slavery, and segregation have further exacerbated problems of quality healthcare, especially for people of African descent. Black women have often faced the problem of both access to quality health care and being powerless before Southern state governments as they attempted their own form of non-consensual birth control. Other groups of women would, in the late 19th and early 20th centuries, also find themselves the victims of the eugenics movement, which attempted to control the birth rates of certain groups to, quote-unquote, improve society. Virginia's forced sterilization law led to the Supreme Court case Buck v. Bell in 1927. There, the Supreme Court ruled that states had the right to sterilize what they referred to as, quote, the feeble-minded, end quote. Other southern states, such as North Carolina, followed suit. By 1960, in fact, the Tar Heel state introduced a sterilization law that disproportionately impacted Black women. Fannie Lou Hamer, Mississippi, was sterilized against her will in the early 1960s, going to the doctor merely to have a cyst removed. Such memories have produced concern and distrust among Black Americans of going to the doctor, further making healthcare access a serious problem across the U.S. South. Some of these current concerns are exacerbated by ongoing problems with sterilization of women, especially those who are incarcerated and are undocumented immigrants. In recent years, the politics of women's health care have become front and center when people think about the U.S. South. A major critique of Southern Republican governors refusing to accept Medicaid expansion in their states during the Obama years was the impact it would have on poor women, who often depended on Medicaid for health care for themselves and their children. Years later, after the Supreme Court overturned Roe v. Wade, Southern state legislatures were some of the most aggressive in passing ultra-restrictive laws on abortion access for women. South Carolina has banned abortion after 6 weeks of pregnancy. North Carolina at 12 weeks. Virtually all abortions has been made illegal in Mississippi, with the exception of rape, incest, or to save the life of the mother. A 2021 report published by the National Institute of Health pointed out perhaps the most serious problem of healthcare in the South: access to care for Southerners living in rural areas. They coined the phrase Southern Rural Mortality Penalty to describe this phenomenon, and found that Black Southerners were most heavily impacted of all. Meanwhile, the 2024 State Scorecard on Women's Health and Reproductive Care, released by the Commonwealth Fund, showed that many Southern states are at the bottom of the list in women's health care across the board. Access to quality care for pregnant women is a major problem in the South, with the states that border the Mississippi Delta, Mississippi itself, Arkansas, Louisiana, and Tennessee, having the highest rates of maternal mortality. Other Southern states, namely South Carolina and Texas, also have high maternal mortality rates. Such structural problems, along with lack of state government investment in healthcare, hostility to federal funding for healthcare, and the economic and environmental stresses of living in the South tied to racism and patriarchy, will all continue to stymie efforts to adequately provide healthcare for women. Our first guest is Dr. Khenia Ragunanthan. Khenia is an OBGYN physician dedicated to serving women in the rural Mississippi Delta. As a student at Duke University, she was part of the Robertson Scholars Leadership Program, which develops leaders committed to serving society. During that time, she worked at the St. Gabriel Mercy Center, running a summer camp for children in Mound Bayou, Mississippi. She later pursued global health work with Partners in Health in Rwanda while studying at Harvard Medical School, and completed her OBGYN residency at University of Pittsburgh Medical Center. Now, she's back in Mississippi, providing care in one of the most medically underserved regions in the country. Beyond her clinical work, she's been a strong advocate for Medicaid expansion and played a key role when extending postpartum Medicaid coverage, ensuring new mothers have access to critical care for a full year after childbirth. Our New South welcomes Dr. Khenia Ragunanthan.
Dr. Khenia Ragunanthan, thank you very much for joining us on our New South podcast. And before we start, we always like to ask our guests to provide our audience with a little background about yourself. So where are you from? Where are you at? And what is it that you do?
Well, first of all, let me say thank you for having me on the show. I'm honored to be included. So my name is Dr. Khenia Ragunanthan. I go by Dr. Ragu, like the pasta sauce for most of my patients. I am an OBGYN practicing in rural Mississippi, in the rural Mississippi Delta. As you can tell from my accent, I'm not from here. I am from Washington, D.C. originally. And so a lot of people, especially my patients, ask, well, how did I end up here in rural Mississippi? And it actually all started through a college experience. So my husband and I met at Duke University. And when we were at Duke, we were part of a program called the Robertson Scholarship Program, which kind of has a bent on service and promoting leadership in service to society. And as part of that program, they have actually developed partnerships with many organizations in rural Mississippi and send college students for summer internships to the Mississippi Delta every year. So I originally came here back in 2009 as a college student and worked at a community organization called St. Gabriel Mercy Center in the town of Mound Bayou, which is the town where I practice now, which is one of the oldest, essentially all Black towns founded by ex-slaves after the Civil War. It has a very rich history. But my husband and I just really liked this area and felt very moved by this area. So as I mentioned, there's a very rich history to the Delta in terms of civil rights history, as well as broader history in American culture, both literary and musical, and all of these aspects. And the health needs here are really, really profound. The poverty is extremely high. The health outcomes are frankly dismal. In a lot of measures, this is the area of the country that has the worst health outcomes. And particularly in my area of OBGYN, we face some of the highest maternal morbidity and mortality, some of the highest infant mortality, just severe complications of pregnancy. So, and then my husband, I should have mentioned, he also goes by Dr. Ragu. He's a pediatrician. And then similarly, some of the metrics on children's health outcomes. There's only in this area, there's actually about one pediatrician for every 4,000 children, which is a pretty startling statistic. And so essentially, we were always interested in care for the underserved and trying to figure out where the best place to practice was. And once we knew about the Mississippi Delta and knew people here and had felt connected to it, even from that early experience, we felt like this was the place we wanted to come back and practice. So it was many years later, but then back in 2021 was when we finally finished our medical training and we ended up moving back here to practice.
And you did your medical training at?
I went to Harvard Medical School and then to University of Pittsburgh Medical Center, McGee Women's Hospital for residency.
And so you're from the Washington, D.C. area.
Yes.
You did your medical training in the Boston area and the Pittsburgh area. But still that experience at Duke drew you back not only to the South, but drew you back to one of the poorest parts of one of the poorest states in this country to do the work that you do with data that shows it is at the absolute bottom of the misery index for women's healthcare in this country at every measure.
Yes.
What was it about the South and that area that really made you decide this is where I'm going to do my work?
No, it's a great, great question. And I think a lot of it is because of what you just outlined. When a place has all of these challenges and has some of the worst metrics, it's a place where like the work that I can do and that my husband can do is most rewarding because it is so needed. And so I think that, there's something also about once you know something, you can't unsee it. So once we saw the level of poverty and saw just the extreme need here, it is honestly in a lot of ways pretty shocking compared to a lot of the rest of the country. And I'm not sure that the rest of the country necessarily is fully aware of some of the conditions in the Mississippi Delta. But once I knew about it, I didn't feel like I could sort of turn away from it. And there is something that is very rewarding about being able to do my job and take care of women, whether that's during pregnancy and postpartum or whether that's for routine women's care. Because, when someone has a problem and they haven't been able to see anybody for it, sometimes for years, it's really meaningful to be able to do something about it. But it is challenging. I mean, I think that because there's so few physicians here, and because the level of need is so great, we all feel like overworked and overtired. And I think the risk of burnout is real. And it is hard, seeing some of the same challenges again and again. We always try to do our best to stay optimistic and stay hopeful and to try to see the long term, because there are a lot of things that may not change, year to year, but maybe decade by decade can improve. And then there are things that maybe, over the course of our lifetimes that we can make a difference. But we may not notice that difference now or even next year or the year after that. But we do try to kind of keep that longer view in mind.
Well, I am, again, very, very pleased to hear that you're doing this incredible work in the Delta. And Dr. Ragu, you just mentioned something that I found particularly intriguing. You mentioned a moment ago that the history of the Delta really says a lot about what health outcomes are like today. And I couldn't help but think of one of the Delta's most famous daughters, Fannie Lou Hamer, civil rights activist and icon, who once said, "I'm sick and tired of being sick and tired." And it sounds like what you're saying is that many of your patients are sick and tired of being sick and tired today. Could you talk a little bit more about how the unique history of the Delta really impacts the health outcomes of people living in the Mississippi Delta today in 2025?
Absolutely. And that's a great quote by Fannie Lou Hamer. And she was, such a civil rights icon and was in this area. We're actually very close to the Fannie Lou Hamer Memorial, which is a meaningful place to visit. So the history of this place, I think, does impact all of modern society. From, it has the history of slavery, but then post-Civil War, the history of the Jim Crow era, and sharecropping and systematic disenfranchisement of the Black population. And the county where I live in Bolivar County is majority African American. It's about 60% African American, and yet, most of the wealth still remains, from the historical legacy, remains mostly in the hands of the white population. And they're, through that whole timeline with everything from reduced economic opportunities to reduced voting rights to poor access to hospitals and healthcare, we see the poverty, we see the low education attainment and the poor school outcomes, and we see the poor health outcomes that are still all present. Our director of the state health department, Dr. Daniel Edney, I think said it best when he just said it to the Mississippi legislature. I believe he said, "Mississippi is not just 50th, we're 50th by a mile." He said, if there were 60 states, we would be 60th. And so, what he's talking about are some of these statistics that Mississippi does have the, highest obesity rate in the country, highest, as we said, poverty rate, in terms of maternal health care, highest maternal mortality rate, highest infant mortality rate, highest preterm birth rate, one of the highest teen pregnancy rates, very high rates of sexually transmitted infections, including now a resurgence of syphilis and some of the highest rates of that. And, from an adult perspective, extremely high rates of diabetes and cardiovascular disease. And so then within Mississippi, the Delta region, that area, which is very rural, which is where I practice, has the worst health metrics within the state.
What are some of the changes that you would like to see, your clinic would like to see, that could help improve healthcare for the women that you see in the Delta?
I think that the big thing that I'd love to see is expanding access to care, and you can come at it from different ways. And so, a lot of times, certainly the focusing on the poor and focusing on the Medicaid population would be a big part of it. And most other states in the United States have expanded Medicaid and expanded the eligibility criteria to allow more patients on Medicaid. Now, that being said, I think that might it's still a political no-go in Mississippi, but I don't see that as the only solution. I see that if the state were willing to make specific investments in, for example, maternal and child health, that they didn't have to call it Medicaid expansion or relate to that. But if we could get patients with diabetes better controlled, patients with high blood pressure better controlled, patients who might be thinking about having kids to have their chronic conditions controlled before pregnancy, that would really change the game.
And it would seem like red tape should be the least of concerns. I mean, some of the data is just stunning. In 2022, 316 babies in the state died before their first birthday. Among babies born to Black mothers, the infant mortality rate is 1.3 times higher than that. The state's maternal mortality rate of 39.1 per 100,000 live births is nearly double the national average. This is stunning.
What is it about working in the rural South that has made your job particularly difficult? Because you just mentioned a moment ago that you've been at Duke University, you've worked at in Pittsburgh, you've been in some urban centers. Mm-hmm. But what is it about working in the rural South that has made your job particularly challenging?
So with the rural nature, transportation is always one of the biggest barriers. Things are just geographically farther apart, and patients live more geographically spread out. In the Delta, it's really a series of small towns, a lot of small towns separated by fields. And everything, first of all, takes longer to get to places. So even if someone called an ambulance, for example, it could take 45 minutes for the ambulance to reach them and bring them. But then due to the poverty, a lot of patients don't have cars. So even though it's a very rural area with no public transportation, people also don't have private vehicles in a lot of situations, or may just have one car that is shared among many family members. And so to actually coordinate, who's using the car when to get to work versus to get to medical appointments, et cetera, can be very challenging.
So clearly you have developed an empathy for the people that you serve, which I think is what all of us would hope with healthcare, folks that work in healthcare. And I was just wondering, you talked about your first experience in this area, the Delta, through Duke. But even before that, what was your experience with the Deep South, either intellectually or tangibly, and what do you think of it now?
It's really interesting to try to unpack that and try to remember what I thought of it even before I came. Certainly, I think my kind of exposure to it initially was probably through literature and through reading. I think that there are so many literary greats from the Deep South and from Mississippi, some of which we even read in high school. And so I think it was the combination of that, as well as probably civil rights history, that was my earliest exposure to the Deep South. And I think that my opinion of it has changed in that, even though we have been talking about the challenges, because again, that's kind of the focus of this interview, yeah. And focus on my work and is trying to address those challenges. I do want to kind of highlight all of the positive things about Mississippi Delta too, and about the Deep South. I think that rich cultural background has led to so much amazing music and art, and just a really special part of American culture. So where I live is considered the birthplace of America's music. The blues is considered, the foundational to basically all other music, including rock music and R&B music and jazz and all of that. And that's still very, very rich here. There's still a lot of live music, and it's something that's really preserved. And we also have the Grammy Museum, which is great and kind of chronicles that legacy. But that and the art, it's hard to put your finger on the exact culture here beyond all that, but people are very friendly. Mississippi is known as the hospitality state, which I understand is then sometimes at odds with its history. Right. However, there is still something to be said for the ethos of people even welcoming, me as an outsider, even welcoming my husband as an outsider. We actually happen to be in a mixed race relationship, which we were worried about a little bit even coming here, but that hasn't been an issue that we've encountered here. And so we've just been struck by the warmth of the people. And I think that's a big part of the South.
Yeah. Well, in some ways, you're part of a lineage of people who have heard and recognized the struggles of people in the South who may have been marginalized, particularly Black folks. And you've come down from the North, right, as an ally to try and help people solve these, in your case, these extremely critical life or death situations. And I think there's something to be said about that. And maybe you could give your idea then of the South that you now live in. We talk about the concept of the New South. Had you ever traveled through that South that you grew up reading about in literature, and how might you juxtapose that to the South that you're actually living in now with all this culture?
It is a juxtaposition. And, I think that the areas of, I think in Mississippi in particular, we sort of see I guess what we'd call the old South and the new South actually in a lot of ways right next to each other are still both sort of alive. So, the Confederate memorials, the plantation homes, the plantation historical sites and things like that are all well and alive here. At the same time, all of the new culture, younger, maybe more connected population, and slightly more progressive bent is alive and well. In my town where we live in Cleveland, Mississippi, and other places, which I feel maybe is more of a New South vibe. But I think, compared to other parts of the South, for example, I guess my other, main experience would be in North Carolina, with Research Triangle Park and a lot of industry and a lot of things like that. I feel that is still quite different from Mississippi, and areas of the New South that have experienced more economic development and more migration into the state rather than migration out of the state are probably experiencing a different renaissance, which maybe Mississippi can one day experience as well. But I think that this still has a lot of ties to the Old South too.
Wow, that's fantastic. You're I think the second person we've interviewed who could be doing their work elsewhere, but has decided that Mississippi is the place that they're going to do their work because of what you were telling Robert, the work that you do there and the success with that work can be an example for the rest of the country on those particular issues. Mm-hmm. So for that and all these other things, you are to be applauded. Absolutely. Thanks so much for joining us on this episode of Our New South. This was a great conversation.
Thank you so much for having me. It's been a pleasure.
From the history of radioactive makeup to all the loony things Henry VIII did to ensure we never stop making movies about him, Weird History is a podcast that answers all the questions you didn't even know you had about the most unbelievable people, places, and events of the past. Based on the hugely successful YouTube channel, Weird History invites you to bone up on what it was like to use a public bathroom in ancient Rome while learning about the single worst year of all time. Don't worry, we missed it by a millennium or so. Then get the skinny on modern history, like the true story behind The Conjuring, and just what the hell Steven Seagal did to get banned from SNL. Let Weird History be your guide to the stranger side of history they don't teach you in school. Because the past is weird, a lot weirder than you think. Subscribe now, wherever you get your podcasts.
The world is growing more complicated by the day, but too often, everyone seems to be operating on the same old assumptions about global affairs. But if you're not sure that world domination by the United States is the right path for America or the world, or if you've got questions about conventional geopolitical thinking, you should check out American Prestige, a foreign policy podcast from a different perspective. Every week on American Prestige, historian and former Bernie Sanders foreign policy advisor Daniel Bessner, that's me, and my co-host, the journalist Derek Davison, analyze U.S. foreign policy from a critical framework that sheds light on myriad topics related to international affairs. So, if you're curious to know what U.S. foreign policy would look like if the interests of all people in the world, and not only rich Americans, were taken into account, then check out American Prestige at AmericanPrestigePod.com. That's AmericanPrestigePod.com. And you could, of course, also find us on your favorite podcast app.
Khenia Haro-Perez is a powerhouse advocate at the forefront of women's healthcare and reproductive rights. As the Virginia State Manager for the National Latino Institute for Reproductive Justice, Khenia is dedicated to amplifying the voices of Latina and immigrant communities in the fight for health equity. Her career is deeply rooted in public service, having worked as special assistant to Congressman Bobby Scott, Chief of Staff to Delegate Jay Jones, and as Executive Director of Meet Our Moment. Our New South welcomes Khenia Haro-Perez. Khenia Haro-Perez, thank you very much for joining us. And as we always like to do at the beginning of our show, please just introduce yourself, your name, where you're from, and what it is you do.
Thank you so much, Kevin. My name is Khenia Haro-Perez, pronoun she, ella. I currently serve as the Virginia State Manager for the National Latino Institute for Reproductive Justice, and I identify as Latina, first-generation American.
And you're in Virginia Beach.
I'm actually based out of Norfolk. I'm from Norfolk, Virginia. Mm-hmm.
And so what's the Latino population in that area?
So the last time that it was, the demographics were taken, we saw that there was about 11 to 12% of the population demographics in Norfolk, but really the Hampton Roads region was Latine. It is growing, though. It has grown considerably. So I do see, if it hasn't already changed, that number has gone up from 10 to 12%.
And how did you wind up there? How did your parents wind up there?
Yeah, so actually I am here by way of Delaware. So like many immigrants or immigrant families, my parents immigrated here, my father from Mexico and my mother from Panama, just in search of a better life. My father immigrated to the States when he was about 17 or 18 years old. And on the East Coast, predominantly the Chesapeake Bay region, which I've been home to for all of my life, there was a lot of factories and chicken plants that were really common in this area. So think Tyson's, Purdue, Conagra. And so these big companies were the home to a lot of immigrants, especially a lot of undocumented immigrants that needed to work. And so that's kind of how my parents landed on the Eastern Shore, Lake Delmarva region. And so my parents kind of met on an assembly line at Purdue. And my mother immigrated with my sister from Panama when my sister was 5 in 1993. And then she met my father. They had me and my brother. And that was in southern Delaware, which is not far from where I presently live now, about 3 hours north of where I presently live now.
And so what has inspired you to do the work that you do based on your growing up in that particular area and growing up as a person of color in a community of color?
Yeah, I think what has inspired me to do the work that I do and kind of shaped everything that I am now is from seeing the work that my parents did and the sacrifices that they made. Growing up to immigrant parents, especially undocumented parents, you are hyper aware to the issues that they go through because you have to be their number one advocate. You have to think, I was the first generation, not even my older sister was born here. And so there's an immense amount of pressure on that first child that's born in the United States to excel, and to really be their parents' wildest dreams, right? And so I had to be everything for my mother. I, for a long time, was my mother's translator. I was her reader. I was her advocate in medical settings. I was her everything. And so being my mother's everything made me extremely aware of the issues that were going on with our community. It made all of the inequities that were prevalent in my community very glaring. You know, having to be in healthcare settings where I'm translating for my mom, translating a policy, trying to make sure that she was going to get the best benefits that she could, or making sure that she was going to get the best care that she could, and dealing with not even just the disparities in healthcare or lack of access, but really just the outright racism in healthcare opens your eyes to so many things at such a young age. And that had such a big impression on me. I say this story often, but my mother didn't vote in her first election until 2014. And so I was a senior in high school at that point. And going with my mother, with her when she voted in her first election after becoming a citizen made the greatest impression on me. It was remarkable. I think being in a position to see your parents vote for the first time in a country where they've paid taxes for over 20 years and never been able to be represented in a system, right? It's much like you said, you're broadcasting from DC. DC's whole thing is being taxed without representation. And that's how I felt about my mother. My mother paid into a country since 1993 because, contrary to popular belief, immigrants do pay taxes. And so, my mother paid taxes into a country for 21 years and was never able to have her voice heard. And so in 2014, when my mother voted for the first time, I cried with her because it was so remarkable that my mother was finally getting to be a part of the electoral process and finally being able to be heard. And so that made a huge impression on me and wanted me to advocate for all other immigrants because, having to pay into a system where you can't even have your voice heard is so diminishing. It's so just crushing.
Already there's so much to unpack about what you just said about the immigrant experience in the United States. I couldn't help but think about the fact that I think both Kevin and I have folks in our family tree who can relate in terms of paying taxes and not being able to vote for generations. We're going to come back to that later on, but I want to ask you a bit about the current state of debate over women's health care and access to health care. And number one, and number two, what is Virginia's unique role in that conversation, especially as it relates to the South and women's health care?
That's a great question, Robert. Thank you so much. Virginia, as you may or may not know, is the last state in the South without an abortion ban. And so what that means is that we have become a critical access point in the South, or a safe haven for many people traveling in across the entire southeastern region, but really the whole of the South, just predominantly the southeastern region. What that means for us is that, we are seeing a lot of people come in, whether that be flying in, driving in, taking a train in order to just receive health care. Every single state in the South has a ban. So especially states that border us, like Tennessee, North Carolina, West Virginia, they're all pouring into the state for care. What that does mean is that it has exacerbated care, right? Right now in the Commonwealth, while the number of clinics that we have has grown, we're still at 20 clinics and 20 abortion clinics to service the entire region of the South is kind of overwhelming, right? So what we're seeing is that, most of the clinics that we have and care, if you've ever been around Virginia, is concentrated around what we call the Urban Crescent, which is Northern Virginia, the Central Region, Richmond area, and Hampton Roads, where I'm based from. What that means, though, because Virginia is such a big state, is that everyone living in rural areas and those states that are bordering Virginia, that are bordering those rural areas, on top of the fact that they don't have access in their own state, probably, they're also flooding into these rural areas where there also isn't a lot of access. And so what we're seeing is people are coming into the state for access, but they're seeing those inequities in rural areas where they're not able to access care. And then the care that we are able to provide within the urban crescent predominantly is being exacerbated by the amount of people that are coming in. To give you an example, in Virginia, well, and really in any state, because of the Hyde Amendment, which precludes, public health insurance from funding abortion care, we're seeing that funding abortions has to be done through abortion funds. So in the state, we have a collection of indie abortion funds that raise money, donations from funders, from small dollars, to be able to fund people that cannot afford their own abortions, that can't afford to drive themselves to clinics, that can't afford childcare, right? To have someone take care of their children while they're trying to access care. And so we're seeing abortion funds that are making up a lot of this difference. And to give you an example, abortion funds re-up their funds every week, probably like every Monday. By the end of the day on Monday, after they've already replenished their funds for the week, they're capped. And so that provides a huge issue, right? A lot of people are trying to flood into the state to receive this abortion care, and there is a gap in care. There's in what people can access. And so we're seeing that a lot of people are coming in for care. There isn't a lot of money that is readily available to folks that are needing this childcare assistance, that are needing transportation assistance, that are needing, hotel assistance, because people are coming in from other states. And so we're doing the best we can in terms of trying to provide adequate resources, culturally competent information that's going to help people get the care that they need in the time that they need it. And just making sure that people are connected to the right organizations that can assist them. And then, larger scale, trying to create some waves on the policy advocacy side and making sure that on the legislative side, we're protecting the current access we have and trying to enshrine bodily autonomy and the right to an abortion in the Virginia Constitution so that no one is criminalized for getting abortion, providers aren't criminalized for providing care, and that people will be able to come into the state and not fear retribution or criminalization from their own home state, right? And so trying to hold all of these things at once, protect the current access that we have, and still want for more.
And to follow up on that, I wanted to ask you about people who are coming into the state. What are you seeing on the ground in terms of class and racial backgrounds, in terms of folks who are coming in to receive access to care? Because I read an interview back about mentioned how, quote, in Virginia in 2022, Black women died at 3 times the rate of their white counterparts during childbirth, end quote. And so we're certainly seeing a lot of class and racial differences in terms of who has access to healthcare. But tell us a bit more about who's actually coming into the state, who can afford to come into the state, and difficulties they face once they get to Virginia.
Yeah, that's a great question, Robert. So to correct that, because that interview was from 2022, unfortunately, that number has actually gone up. The current Black maternal mortality rate is about 4 to 1. So 4 Black women are dying on the table as opposed to their white counterpart, right? And that's staggering in Virginia and completely disheartening that that number has gone up. And what we're seeing is that, a lot of different people are coming into the state for care because there's a ban everywhere. It's going to affect everyone. But what we're seeing is that the folks that are most affected by this and the folks that are going to see these disparities even more is going to be Black people and other people of color.
In bringing this up, and since you mentioned the 2022 date, we know now that from the summer, in July of 2024, the Commonwealth Fund released a 2024 state scorecard on women's health and reproductive care, and a number of southern states received the lowest overall scores measured by maternal mortality, insurance, care access, breast and cervical cancer, and more. So in your view, and given what you do, how do we rectify that? What can be Virginia's role, which is already a lifesaver for so many women in the South? What can be done?
So I think there's a lot that can be done. Thank you for that question, Kevin. I think first and foremost, we should be leaning on existing organizations and partners in the state that are doing a lot to mitigate this issue, right? We have a strong partner in the state called Birth in Color that does a lot of advocacy and does a lot of direct service work to help mitigate the Black maternal mortality rate. But I think in Virginia, what's really top of mind for us is having those legislative wins and making sure that we get each of these legislative wins. I think it's imperative that we get these legislative wins with so many people coming into the state for care. We have a lot of access in Virginia, right? Like you can get an abortion up to 26 weeks in Virginia. You can get abortion pills by mail. There are no waiting periods in Virginia, no mandatory ultrasounds, things like that we've rolled back that other states didn't have. And so we have that. We want to keep that. And we want to make sure that in other future administrations, those rights aren't subject to be taken.
Given what you've just said and what you laid out about the South, what are your hopes most broadly on this issue, not only in the state of Virginia, but throughout the entire southern region?
One of my biggest hopes right now is that we're able to pass the constitutional amendment. I think that's top of mind for a lot of stakeholders in Virginia. My hope is that we are able to pass legislation over these next 2 years that's going to protect the access that we currently have. And my hope is that we'll mirror other states. About 7 of the 10 states that had abortion measures, up for a vote last election passed. And so that's super comforting for us because it provides a great precedent. Other states that look a lot like ours too are passing a lot of these initiatives, right? Our neighbors up to the north in Maryland have passed a sweeping protection for abortion access. And so that's comforting for us to know. And our hope is that we're able to mirror a lot of those other mid-Atlantic states that have been making waves, mirror other states that kind of look like us demographically, because we do have great access right now, but we want to make sure that we're protecting people. And my hope is that we're able to protect people.
And just for a moment, I want to just zoom out from Virginia and look at the South as a whole for a second, and to really ask you the question of how we got here in terms of reproductive rights across the region. Because as you mentioned in sort of our interview, even before the Dobbs decision, it was quite clear that access with the care across the South was unequal. It was uneven. There were already some serious issues. I can tell you, living here in South Carolina, we're already seeing this. Give our audience a sense of why exactly the South has had these issues of inequities in terms of access to care and like even before the Dobbs decision.
So to zoom out a bit, in 1973, Roe versus Wade became the law of the land. And there were so many clinics. I mean, when you think about Virginia and the amount of clinics that we've lost since 1973, it's been great. There used to be so many more in Virginia, more than the 20 we currently have. And that was the case in a lot of other states in the South too. But as the years went on, and with different iterations of the Supreme Court, a lot of those protections started to get rolled back, right? You started to see measures getting passed that kind of provided amendments to this care, right? So states were passing laws that instituted waiting periods, that instituted mandatory ultrasounds, and they started to move away from a trimester framework to a viability framework. And what that means is that states were deciding when, gestationally a fetus was viable instead of marking an abortion at a trimester, right? And so before, maybe you could receive an abortion in the 3rd trimester, but then a state ruled that a fetus was viable, at another point in gestation, and they rolled that care back, right? So it was a lot of legislators, policymakers making that decision instead of providers on when a fetus was viable and when it should be taken full term, if that makes sense. And so as a lot of those protections were getting rolled back more and more and more through different cases, we saw that access kept getting diminished and kept getting diminished. A lot of clinics were closing because a lot of their care started to be precluded, and providers were getting criminalized, right? Like providers didn't want to be in a state that was going to criminalize them for providing a certain amount of care. And so that's when we started seeing clinics dwindling, and that care being stripped away gradually, bringing us to this point now where, in Virginia, a few sessions ago, we were able to pass laws that did away with trap restrictions, right? What I mentioned, those waiting periods, those mandatory ultrasounds, things like that. We rolled all of that back. Other states never did. And so because of that, other states were starting to see this lack of access. Virginia was trying to protect its current access and trying to protect certain laws. And it kind of brought us to this moment where a lot of other states ended up not having many protections at all versus other states that had more and started to protect that access when they were rolling back these trap restrictions.
And since we're just talking about the South, we talk kind of philosophically on this show about what the South is anyway, particularly what the New South is. And you are very much representative of the New South, being a progeny of immigrants. What is the South to you?
I think for me, the South is home. I think a lot of people kind of write off the South as a place that no advancements can be made. That's kind of a lost cause. And I just reject that entirely, mostly because this is my home. And there are so many people that look like me and that share my demographics and that share my inequities in life here, that live in the shadows, that don't get represented. And to me, what the South means to me is it represents diversity. It represents a changing demographic. So many people are coming into the South now to work, to live. It's a beautiful life. And I have been committed to staying here because I think it's important for people from the South to stay here and to continue to do this work, to build trust within our own communities, to see the advancements that we want to see. It's important for me because if I don't stay here and do this work, I don't know who else will. I don't know who else is going to represent the Latina community and advocate for them in a way that's culturally competent and in a way that's going to be trust building, in a way that's going to be representative of us as a whole. To me, the South means that there's so much hope. To your point, I think so many other states look to us for what we're going to do to shape their own decisions around policy change on abortion access, because if something can change here, then it can change anywhere. And so, yeah, I think it's representative of hope. I think that there's so much to be done here, and there's so many ways that we can make change. And there's so many great people here already doing the work and changing the landscape of what we're seeing. I mean, I think you're going to see it. You see it in our legislature, how our legislature is changing. You see it in, just how access to healthcare is opening up slowly but surely, right? Like in Virginia, a few sessions ago, Medicare Access for All was passed, ensuring over 400,000 people, right? And so you're seeing those changes. There is a hope for a future. And I think the future is bright. And I think that is how I feel about the South, the New South in general, is that the future is bright and there's so much work to be done. And people from the South should stay and see it through.
Well, once again, thank you.
Thank you so much for having me.
So, Kevin, I think this episode of Our New South was perhaps the most eye-opening of the entire season. Both of these women are doing tremendous work when it comes to women's health care, work that is often underappreciated, underreported on, and is frankly left out of the margins of history. But this is work that, again, affects people's everyday lives. And whether it's Mississippi or Virginia or all the states in between, it's quite clear there are many women doing necessary work to help their fellow women with their healthcare needs.
Absolutely. And one of the things that struck me about this as we were going through it in our conversations is I think the rest of the country right now, when they think about women's healthcare, access to healthcare, the argument over abortion, we hear about it from Capitol Hill. We hear about it from lawmakers and legislators. We hear about it from lawyers. But we really don't hear about it from the foot soldiers in this fight. And that's who we just talked to. And I think that will resonate with listeners. It certainly resonated with me.
But what I think is also intriguing about this episode is how it showcases the best of the current South, the best of the New South. And I think next week's episode, our final episode of the season, also points in that direction. We're transitioning from women's healthcare to hip hop, but I think there are some similarities there in terms of how people make assumptions about the South in both topics. But as was the case with women's healthcare, next week with hip hop, folks will find out a lot about hip hop's history in the South. That does, yes, include Outkast, of course, but includes so much more than that.
Sure. And the conversation that we have, which people will hear in relating it to healthcare, it really has been a healing force for so many people in the South. And I think that hip hop in the South, particularly more than in the rest of the country, has been subversive and has brought voice to people in the South and people who migrated to the South, who were searching for something to say about the region that they now live in.
Searching for something to say, said Kevin. You make it seem as though the whole region may have something to say about hip-hop. And I think next week's episode will certainly showcase that. Although I do want to warn the listeners, we will cause no rap beefs with our episode next week. So it will be healing, but not divisive.
Correct.
You know what I'm saying? It's like we got a demo tape and don't nobody want to hear it, but it's like this the South got something to say.
Our New South is presented by Levine Museum of the New South. Levine Museum connects the past to the future to realize the promises of a New South. To learn more and donate to projects like this, visit museumoftheNewSouth.org.
Our New South is produced by Next Chapter Podcast. Thanks to editor and sound designer Kyle Murdoch, producers Brian Douglas, Alexander Piñeres, and Cliff Whitfield, senior producer and writer Byron Hunter, and executive producers Jeremiah Tittle and Frankie Abbott. Please follow the show, subscribe, rate, and review on Apple Podcasts, Spotify, YouTube, Amazon Music, or wherever you listen to your podcasts.
Learn more at nextchapterpodcast.com/Our New South.
Thanks for listening.
The South got something to say.
From the history of radioactive makeup to all the loony things Henry VIII did to ensure we never stop making movies about him, Weird History is a podcast that answers all the questions you didn't even know you had about the most unbelievable people, places, and events of the past. Based on the hugely successful YouTube channel, Weird History invites you to bone up on what it was like to use a public bathroom in ancient Rome while learning about the single worst year of all time. Don't worry, we missed it by a millennium or so. Then get the skinny on modern history, like the true story behind The Conjuring, and just what the hell Steven Seagal did to get banned from SNL. Let Weird History be your guide to the stranger side of history they don't teach you in school. Because the past is weird, a lot weirder than you think. Subscribe now, wherever you get your podcasts.
Next Chapter Podcasts.